Hello everybody, my name is Dr. Vijay Agarwal and I'm the lead medical oncologist for Apollo Hospitals, Bangalore. Today we have here with us Dr. Satish and Dr. Vikram, who are the neuro-oncology team here. Dr. Satish and Dr. Vikram, would you like to introduce yourself, please?
Thank you. I am Dr. Satish Satyanarayana. I am the lead neurosurgical consultant at Apollo Hospitals, Bannerghatta Road. I have a very special interest in neuro-oncology, and we thought we'll use this occasion to talk something about neuro-oncology to introduce this topic. And Dr. Vikram.
Thank you, Dr. Satish and Dr. Vijay. I am Dr. Vikram Maiya. I am the senior radiation oncologist at Apollo Hospitals, Bangalore. I have a special interest in stereotactic radiosurgery and in neuro-oncology, which is an integral part of our oncology training.
So, Dr. Satish, would you like to introduce everybody to the concept of neuro-oncology? What does it actually mean and what does it entail?
Yeah. So, neuro-oncology, when we use this term, Vijay, we are basically discussing about tumors and disease processes, that is the neoplastic processes which occur in the brain and the spine. And as neurosurgeons, as you are all aware, we deal with the brain and spine all the time, and a large part of our practice is centered on treating patients who have brain tumors. So very briefly to say, there are tumors which are primary in the brain which can be benign, and in which case surgery is the mainstay of treatment, and there are malignant tumors which unfortunately is very commonly seen, and in this case we will have to differentiate whether they are primarily arising from the brain or they have secondarily reached to the brain and the primary is elsewhere in the body. So I am sure Dr. Vikram will be able to contribute a little more to throw light on this aspect. Then we will discuss the other aspects of it.
So, Dr. Vikram, obviously, Dr. Satish mentioned about things like metastasis, benign, malignant, primary and secondary. Can you tease out the differences between these things and just explain to the audience what they actually mean?
Okay, Dr. Vijay. In fact, benign tumors of the brain are certain tumors which are not very aggressive, but they grow as a part of the body itself and they manifest the condition with respect to pressure symptoms. They don't spread from one point to the other. Malignant are very aggressive type of brain tumors. You could also call them as a brain cancer, and for them they have a tendency to go within the brain itself but not outside the brain. Certain conditions also go to the spine, which we will be discussing later on. Primary malignancies are malignancies which are there in the rest of the body, and they have a tendency to spread to the brain or to the spinal cord or to the lung. They might be arising from the lung, they might be arising from the rectum, they might be arising from the liver, or they might be arising from any other part of the body, which can go to different parts of the body as a spread, and that is called as metastasis. This is what we call it as a secondaries to the brain, especially when it is coming from other parts of the body.
Dr. Satish, how do you suspect that someone's got brain tumor or brain cancer? How do they present to you, and when does it actually flash that, oh, he may be having a brain tumor?
That's a very good question, Vijay, because some of the common symptoms of brain tumors also overlaps with some of the common symptoms patients without brain tumors also have. Typically, for example, headache. Now, headache is a very universal symptom. Most patients will have some form of the headache or the other, especially like migraine. But there are certain patients with brain tumors who present with, as Dr. Vikram rightly said, pressure symptoms in the brain. Now, as we can all realize, the brain is housed in a closed cavity, which is the skull, and the skull is non-expandable. So, whenever there is a new growth in the brain, slowly but surely the tumor keeps increasing, and initially it will be quiet and there will be no symptoms. But when it reaches a critical mass, the headaches increase and the frequency increases, the severity increases. Typically they are accompanied by vomiting and also by some visual disturbances. This is when we find that these patients may be red flagged, that they may be having something more than a normal type of headache. A lot of these patients with migraine we do not need to investigate, but these patients who have these red flags, typically these are the ones which we would screen them additionally with investigations in order to find out whether they really have a brain tumor or not.
So, Dr. Vikram, what investigations would you consider doing for these patients who you may have suspected that they may be having brain tumors?
Okay, Dr. Vijay. In fact, whenever a patient comes to our clinic with any types of symptoms like headache or nausea and vomiting, so the first most important thing what we need to do is the clinical examination. The clinical examination reveals out a great deal of information. Then, based on what the problems are, we would like to see whether we need to do a CT scan or an MRI or both in certain conditions. And then after that, sometimes everything becomes normal. Then we need to see whether we need to do an EEG or any other blood investigations which is required. But these are the basic investigations which usually the doctor expects so that we can reach a particular diagnosis. Then after that, we usually hand them over to our neurosurgery team and then see what needs to be done next.
Dr. Satish, of course, whenever we talk about a cancer or a tumor, I think one of the things that do come up in everybody's mind is that do we need to do a biopsy? I think there is it's a very complex decision where as far as the brain is concerned, where it's not as easy to reach and maybe associated with some residual effect. So can you throw some light on as to what type of tumors you would consider doing a biopsy and which ones you would avoid?
Yeah, so that's again a very important question, Dr. Vijay, you have raised. Typically, when you suspect cancer elsewhere in the body, the ability to get a diagnosis is quite easy. Sometimes in the outpatient department itself, all you need to do is a needle biopsy or something, which is a daycare procedure. But in the brain, it does become little more complex. Quite often, the mass has to be removed. So we don't necessarily do a biopsy, but we do a surgery which is called as a craniotomy in order to remove the entire mass or the bulk of the mass, which will also give us the answer as to what the tumor is. Typically, we need to do it so that the patient's pressure symptoms are relieved, otherwise they could be life-threatening. So sometimes that itself will give us the answer as to the type of the tumor, the grade of the tumor and the stage of the tumor. If it is benign, surgery itself can be curative, and sometimes in very difficult locations we do consider removing most of the tumor, but we might be deliberately leaving behind a small part of the tumor which is in an extremely critical location. There Dr. Vikram's role is very important, because in such small residual tumors in very critical areas like brainstem, cavernous sinus, etc., they will be able to offer the patient without invading again by a non-invasive way, something like radiosurgery, wherein we can make that small part of the tumor not to grow again. So surgery followed by radiosurgery is the answer for benign tumors. But in malignant tumors, obviously your role is very important as well. So in malignant tumors, the diagnosis is often obtained by primary surgery. In extremely deep-seated small lesions, we do what is known as a stereotactic surgery, wherein we put a needle through a three-dimensional frame, and through that we take a small part of the tumor, which will give us the answer. That itself will suffice to establish the diagnosis, following which they will probably be going to radiotherapy or chemotherapy or a combination of that in what would be a multidisciplinary approach. We will sit with the all the three disciplines together, and then we will figure out what is the best next course for the patient.
So clearly in our setup what we have is a multidisciplinary team approach to patient management, where every patient is discussed in a multidisciplinary team meeting that involves medical oncologist, neurosurgeon, radiation oncologist, pathologist, neuroradiologist, and nuclear medicine physician, all in the same room having discussed the patient. But in terms of the surgery, they tend to be quite complex.
Yeah.
So what is the state-of-the-art facilities that you have or that you use in a day-to-day practice to enable you to give the best outcome in the safest possible manner?
Right. So these patients often have tumors in eloquent areas, for example. Now, all parts of the brain are important, but certain parts are extremely more important. For example, if we have a patient with a motor strip, let's say a tumor, and the patient is very cooperative, an advanced way of doing it is what is known as awake craniotomy, because we can continuously monitor the patient when the surgical excision is being done. For that, we need very advanced kinds of monitoring, neuromonitoring intraoperatively. The neuroanesthetist role is extremely important. So that is just an example. As a technology platform, most of these surgeries are nowadays done with 3D operative microscopes or endoscopes depending upon where the tumor is located. And in order to enhance the surgery even more safe and make the surgical environment safer, we use what is known as neuronavigation as well. Intraoperative neurophysiological monitoring is an integral part of the surgical approach. With all these modalities, which fortunately we have at Apollo Bannerghatta Road, we are able to deliver that kind of fine approach to the patient's problem, which could be comparable to any of the best centers and the best practices anywhere in the world.
Yeah, that is very, very impressive, Dr. Satish. Clearly, despite the best effort, occasionally because of the criticality of the lesions, we're not able to remove 100% of them,
Yes.
though the intent to treat is to remove 100%. And that's when kind of the radiation kicks in to kind of deal with
Yes.
what may be left. So Dr. Vikram, can you throw some light on what does SBRT-SRS mean, and how does it help our patients, and how is it given?
Okay. Actually, what happens is most of the benign tumors in the brain is dealt with surgery. The neurosurgeon does a good job, he removes everything. But unfortunately, in certain conditions where certain things cannot be removed fully, especially in pituitary tumors, which is going into the nearby vital structures, or there is a acoustic schwannoma, which is again going inside or causing a lot of issues in and around these nerves. In such conditions, after surgery, a debulking surgery, usually radiation comes into the picture. And for such conditions, we use something called as a stereotactic radiosurgery. What is stereotactic radiosurgery is pinpointing the radiation only to the tumor area and completing the whole dose of radiation from 1 day to maximum of 5 days. Of course, we require a lot of imaging before that, especially we require the previous imaging before the surgery, and then after the surgery, the imaging. And then we also take a CT scan and fuse all these images, and we are able to pinpoint where the tumor is. Along with the neurosurgery team, with Dr. Satish and his team, what we do is we mark where to give the radiation and where not to give the radiation and do a planning. And the treatment is delivered from 1 day to maximum 5 days. In certain benign conditions where surgery again tumors, especially benign, is with respect to surgery. Surgically, if it is not cannot be done, or if it is a difficult thing, then a stereotactic radiosurgery comes into the picture. It is delivering very high dose of radiation to a very small area in a limited period of time. In certain conditions called as metastasis, which has come to the brain from various other parts of the body, stereotactic radiosurgery can also be given if there are limited metastases like less than 4, and they are they're pretty much not causing any pressure symptoms. Stereotactic radiosurgery can be given to those conditions also.
Clearly, you mentioned that a lot of the planning that has been done happens with the consultation of the neurosurgeon. I think in Apollo we are fortunate that we have both the neurosurgical and the radiation team under one roof. Can you throw some light on how does that help you plan the treatment better and improve outcomes or safety?
Excellent question, Dr. Vijay. So what happens is when we are having a multidisciplinary approach over a condition, there is an input by the surgeon. The surgeon would have gone inside, the neurosurgeon, Dr. Satish, would have gone inside, and he knows what the situation is. He knows where the tumor was, or tumor, where was it going, and where was the residual tumor. So with his approach, we really can make out where exactly we are treating and what exactly we are treating. There are certain conditions which can be answered only by the neurosurgeon, because he has seen through when he has opened up or when he has done a surgery. So it becomes very important for us to take the neurosurgical help, especially in certain pituitary tumors or in arteriovenous malformations, or with respect to acoustic tumors also. That's why the multidisciplinary team approach for a condition like this is very important.
So, of course, going along the patient's journey, the intent to treat the vast majority of brain tumors is to remove the whole tumor. And if you're not able to remove the whole tumor, give some form of what we call as an adjuvant treatment in the form of radiation to kind of deal with whatever may not be left behind. But clearly, at some point in time, for a small number of patients, the tumors would still progress.
Yes.
In that case, how would you deal with that?
So that's true. I mean, if we are dealing with malignant conditions of the brain, especially the primary malignant conditions, very commonly we talk about tumors like glioblastoma multiforme, astrocytoma, malignant astrocytoma, etc. These are intrinsically they are quite difficult and challenging tumors to deal with. Oftentimes these spread into areas of the brain which functionally, to preserve the function, we may deliberately leave behind some part of the tumor. Therein the role of radiation oncology is extremely important, and after they have finished the course of the radiation oncology, radiation treatment, again your role becomes very important, because we also have to attack the tumor in another way, which is possibly by the medical oncology. There have been several advances in medical oncology as well, and the main challenge I believe is for the drugs to cross the blood-brain barrier.
Absolutely.
And herein your role is very important. Probably I might want to know what exactly would you do to choose such an agent which will cross the blood-brain barrier, have some effect on the brain tumor, and mop up those cells which after surgery and after radiation oncology also, there are some malignant cells still left behind, which possibly can be addressed by medical oncology.
Yes, Dr. Satish, see, in terms of the treatment of neuro-oncology from the medical perspective, I think a lot has changed, particularly in the past 5 to 7 years. A lot of molecular diagnostics have now become the standard of care in terms of how do we identify particular tumors and put them in certain sections that can predict the outcome and help us decide what medicines to be given. So nowadays we do molecular testing as routine. As you already know, we've been sending them out for regular testing in terms of IDH mutations, ATRAX mutations, 1p19q code deletions, MGMT methylation, BRAF, and so forth. So these have now become a standard of care for us in our practice here at Apollo. Once we've got those information, that helps us kind of identify patients are likely to respond to which particular treatment and not.
Targeted therapy is what you would call it.
Correct.
I think.
Absolutely. So there are certain drugs that cross the blood-brain very well, and sometimes we combine that with radiation, and sometimes we give it to them after the radiation, and sometimes even both. Both. Despite that, if there's a recurrence in a particular place from the tumors, now targeted therapies such as VEGF inhibitors have now become the standard of care that we use in our practice routinely. Having said that, like I said, molecular diagnosis helps us further refine the treatment. So if someone's got a BRAF mutation, we look at BRAF inhibitors, and now clearly immunotherapy is also coming in the forefront of treatment for brain tumors. We are now able to look at certain markers that will help us identify which patients are likely to respond to immunotherapy, and then tailor make those immunotherapy treatments based on that. So I think we have come a long way in the past decade or so in terms of our ability to use drugs, refined drugs that cross the blood-brain barrier, use targeted therapy as well as immunotherapy for the best benefit of our patients.
Thank you, Vijay. So I think you nicely encapsulated the chemotherapy aspect of it, because as we viewers will realize, brain tumors are not just primarily treated only by the neurosurgeon, because unless you have a very comprehensive setup wherein different specialties come together in the best interest of the patient, which is typically done in a multidisciplinary meeting where all these specialists join together, and sitting with the patient's reports, typically after the surgery, we will know the stage, the grade and type of tumor. We can even predict what is going to happen if the patient is untreated from there onwards, or only if radiation is done, what will be the outcome. And once we know that, when we add chemotherapy also to it, so then we will know that what is the best case scenario for the patient in a given patient. Sometimes we also get pediatric patients, Dr. Vikram. So these pediatric patients are to be treated in a little different way. They have different challenges in terms of their pathology. They have also different challenges in terms of treatment. So would you like to throw some light upon treatment of pediatric oncology patients, especially given the fact that you have very good platforms nowadays to pinpoint the radiation and other aspects of their treatment?
Thank you, sir. Pediatric patients treating with radiation is a very challenging thing for any radiation oncologist or anybody as such, because they are all children and they are all growing, and we don't want to have a long-term complication with respect to our treatment per se. Luckily, most of the pediatric tumors, the malignant ones, are curable because they won't be very much extensive, and we have molecular diagnostics which actually categorize us and help us out in differentiating the different types of malignant pediatric tumors. Some of the important ones are medulloblastomas, germ cell tumors or germinomas, and then ependymomas might be anaplastic ones. And treating them is slightly different from rest of the brain tumors, because in most of them, surgically, yes, how much ever debulking is possible can be done, but these tumors have a tendency to spread to the spine. So we need to do a combined modality with respect to surgery, with respect to radiation, and with respect to chemotherapy. All three needs to be given sometime or the other, and it is very important for us to do so. So basically, after surgery, the radiation what we give in medulloblastomas and ependymomas, anaplastic ependymomas, are germ cell tumors, are something called as craniospinal irradiation, in which we have to treat the whole of the brain and of the spine in one single go. And this is a very challenging thing, especially when we have children, and because they will not be stable and we have to pinpoint the radiation. So we usually use the benefit of anesthesia. We anesthetize the kids and then we go ahead with this radiation if the children are not cooperating. So this is a very prolonged and it is a very painstaking treatment, but the outcomes are pretty good. And this has to be given. After this, we have to give chemotherapy also, and that would complete the whole treatment. At Apollo Cancer Centers, we have the benefit of using something called as a proton beam therapy, which is very useful in treating these craniospinal irradiation, especially in children. And it has reduced the immediate and the long-term side effects to a very great extent.
I believe this is the only such facility which is available in the whole of Southeast
Yes.
Asia itself. And it's a very high-end facility.
Exactly.
And we have a seamless way of getting those patients treated in Chennai, where the proton beam therapy unit exists. You talked about medulloblastoma, which is a very important subject in pediatric brain tumors. Not very long ago, Vijay, we used to operate these medulloblastomas and we used to give them a very poor prognosis. Maybe just as short as 25 years back when we were training, and 80% of them would recur in no time. The second surgery becomes extremely difficult, and these patients didn't have much options once there was a massive recurrence in craniospinal way. But nowadays it's a different thing altogether. In the last 10-15 years, the number of chemotherapeutic advances have been quite dramatic. In fact, we can now reverse the ratio and say that 80 to 90% of them can either be going in for long-term remission. In fact, we have seen them for 10-15 years now. They're tumor-free. They're leading a near normal life given the kind of malignancy they had. Would you like to throw upon some light on that?
Yeah, intensive chemotherapy has now become the mainstay of treatment for medulloblastoma, along with radiation for any of the residual disease that might be there. And I think the outcomes with intensive chemotherapy are quite good. The thing about children is that one of the things we worry about with any brain tumor is the neurodisability. That gets left behind with them. They are growing, they are learning, and at certain level, cognitive effects that pick up with it. So chemotherapy helps us remove some of those things, because they are drugs that are administered in the blood system, and we are getting good outcomes from chemotherapy alone in terms of medulloblastoma, and if combined with radiation, if required, depending upon the residual disease that is there. So I think medulloblastoma, medical oncology has clearly changed how we look at patients with medulloblastoma and how we treat them.
I think one of the reasons is because previously the pathology report is all that we would depend upon to plan the treatment. Now we don't stop just at histopathology. As you rightly said, you go into deep molecular genetics based on the tumor specimen, and that will give you a clue as to what agents these patients might benefit with. So it's in a way tailor-made for that patient.
Absolutely.
And availability of those agents, managing those complications and giving those kind of high-end chemotherapy. Luckily you do have all those facilities
here. So that's
here.
the thing. So we do feel that when we're treating pediatric oncology, our multidisciplinary team is probably the most crucial in them, having a setup that can deal with high volume of patients.
Yes.
We know that wherever pediatric tumors are treated, if they're treated in high volume centers, the outcomes are much better than if they're not treated in high volume centers. So we are fortunately that in Apollo Bannerghatta we have all of these facilities to enable intensive chemotherapy, high-end radiation, complex surgeries that can all be done under one roof, both for adult patients as well as for pediatric patients. And clearly one of the biggest advantages we have is the multidisciplinary team approach. And we know that from lots of evidence that exists across the world, that an integral approach, a multidisciplinary team approach is probably the only way forward.
Yes, it's very important, and I think in conclusion we can say that the moment a tumor of the brain is diagnosed, not too long ago people would think that's like a death sentence kind of a thing. We do now know that if you go to the right place with the right team of people doing the right kind of job, it is possible to have a good outcome in majority of these patients. At least we can give them the state of the art, what is available, the best practices in the world, evidence-based treatment, the technology platform, and the expertise, given that all of us have worked in institutes abroad and in India where we have dealt with hundreds of these patients.
Absolutely.
What do you say, Dr. Vikram?
I perfectly agree with what you're saying because a team approach is the best and the only approach for such a condition.